Good afternoon. I invite you to this roundtable discussion on urinary tract infections and antimicrobial resistance and novel strategies how to combat this. My name is Florian Wagenlehner. My conflict of interest, I stated here, I'm an investigator of GSK and a GSK study, and am I consulting GSK with regards to antibiotic resistance. I have two esteemed speakers with me, which is José Medina-Polo from Madrid, Spain, who will give a case presentation on a typical case in urology of a patient with infection and antimicrobial resistance. And we also have Tommaso Cai from Trento, Italy, who will give you some insights on the novel developments in the treatment of antimicrobial resistant infections. So without further ado, I will hand over to José Medina-Polo to present his case on a typical case of antimicrobial resistant infection in urology.
Okay, thank you, Florian. My case is about typical women that attend to our clinic. This is my conflict of interest. Is a 35 years old female that came to my clinic because 24 hours of symptoms with dysuria, urgency, and hematuria. No fever, not flam pain. We don't suspect pyelonephritis. And I had some questions. First of all, what is the diagnosis work up? And what is the most possible diagnosis? And what is the management that is recommended for this woman? First of all, I would like to state we are in the ECA group and we recommend to you the questionnaire, and the ACSS questionnaire is a valid tool to evaluate the symptom. And it's important to evaluate the symptom, in my opinion, because we are thinking about an acute cystitis in this patient. And it's important because, first of all, we have to classify it is uncomplicated or complicated cystitis. According to the data that we had in this patient, it's not complicated. That includes all the cystitis in non-pregnant women, also a pyelonephritis in patient with no risk factors and uncomplicated UTI, and then go to complicated that patient has had anatomical and functional abnormality, and also men. And the other point to stress that the questionnaire is very important is because this is a case, it's not a recurrent case, and we only had to treat the patient with the symptoms. The uroculture is not necessary. So this is the one I like to state. So we follow the guideline, and we need to choose an antibiotics. A problem can be the resistance that it increase, and the guideline recommend that fosfomycin or nitrofurantoin should be the first line treatment for this patient. This is sometimes the way why the women come to our clinic, but sometimes there are several episodes of UTI. For example, the same patient after a year had 5 uncomplicated UTI is related to sexual intercourse, and in this case we need a culture. As you can see, we had an E. coli isolation, is sensible to most of the antibiotic, not to ampicillin and amoxicillin. I'm sorry that it's in Spanish, but it's a real case. And in this case, if we think about the diagnostic workout and the management, the diagnostic workout should include an ultrasound to correct evaluation, because it's not the first episode, and we need to evaluate the treatment. And usually we recommend a long treatment. And the problem with this patient, we started with the treatment, and 15 days after, 2 weeks after this episode, the patient came back again to my clinic. As you can see, the resistance rate was very important, not only to ampicillin, also to cefepime, to fluoroquinolone. So now we had to deal with ESBL microorganism that is difficult. So this is the thing that we had in mind, that sometimes the patient started with an uncomplicated cystitis that can be developed to a very complicated microorganism to treat. So it's not only in my clinic, it's happening in whole Europe. You can see in this graph of Spain for the surveillance alert of infectious disease that is increasing the resistant bacteria to cephalosporin, fluoroquinolone, and aminoglycosis. It's important to select the correct antibiotics. Fosfomycin and nitrofurantoin is a good alternative, and we have to have in mind. And the government, for example, in my country, I come from Spain, there are several laws, several programs in order to avoid resistance to antibiotics. And this is that we have to do. We have to select the correct antibiotic because there are many patients with recurring urinary tract infections. As you can see, more than half of the women had an infection during the life, but 2% of the total women are going to have very frequent infection in their life. So we have in mind that infection is an important topic and we have to deal correctly. Let me include some poster in my city, in Madrid, that we have to bear in mind that we need to treat correctly the infection. Antibiotics we need to put the time that is necessary and don't use when it's not necessary. This is my point that I want to describe with my clinical case.
Yeah, Jose, thank you very much also for elucidating how you educate also physicians and maybe on a shared decision also the patients with these posters. I think that is very helpful also from an antimicrobial stewardship perspective. And now I think we come to the point, Tommaso, where we also have to deal strategies how we combat this development. I mean, this is a very typical case. It's an uncomplicated cystitis. We see that every day in clinical practice, it is treated and it is repeatedly treated. And then we have a more complicated, more complex issue arising. So what would be your strategy, how, or some of the strategies, of course, how we can in the future treat and emerge those patients?
So thank you, Florian, for this important question, because as you will know, the recurrent urinary tract infection are a very most common infection, like Jose clearly highlighted in this very interesting and very common clinical case. Moreover, the burden of the disease is very high, both for the patients and then for the community, because the patients have a decremental of quality of life, of course, and both to the community because the recurrent urinary tract infection management is strictly related with the risk of bacterial resistance.
And we have to emphasize that the quality of life is dramatically reduced in those patients that have recurrent cystitis.
Absolutely. We need to discuss with the patients about the possibility that a new episode of a recurrent urinary tract infection is a reason for a decremental of quality of life. Moreover, the patients we need to discuss with the patients about all the strategies that we need to perform in everyday clinical practice in order to improve patients' quality of life, in order to decrease the number of recurrence, and in order to avoid antimicrobial resistance.
Yes.
In this case, probably in the case that Jose showed before, the counseling, specific counseling about behavior modification, lifestyle modification is essential, both to reduce symptomatic episode and both to reduce the incidence of resistance, of bacterial resistance.
Yes. Nevertheless, we need new products, and this is now what we are showing, what you're showing us, what is in the pipeline in the development, not only for the uncomplicated, but also for the recurrent and the complicated urinary tract infections. Please.
Okay, thank you, Florian. Let me to give you an overview of all products in development for urinary tract infection. This is my conflict of interest. I have no potential conflict of interest to report. As we all know, as we discussed before, the antimicrobial resistance is a real challenge for all healthcare systems, and the World Health Organization estimated that by 2050 we will have one death every 3 seconds due to multi-drug resistance. Is a dramatic situation. Moreover, the World Health Organization asked industry to increase its effort to make new antibiotics, especially against and active against multi-drug resistant bacteria. This is the actual scenario, and we need to take into account. But what is new in the management of urinary tract infection? What about uncomplicated UTI in acute and sporadic form? What about recurrent? And what about complicated UTI? I would like here to highlight that in my presentation I included only late-stage development antibiotics assessment. Moving to the uncomplicated urinary tract infection, what are the investigational drugs that we have in the company pipeline? First of all, gepotidacin. Gepotidacin is a novel bactericidal orally administered antibiotic that is able to inhibit bacterial DNA. Gepotidacin in this recent in vitro study is showed a promising activity against E. coli, in particular against E. coli resistant to fluoroquinolone, against ESBL producing E. coli, as Jose demonstrated that is a real challenge in everyday clinical practice. And moreover, gepotidacin is able also to be active in all strains resistant to other standard of care antibiotics. Moreover, another interesting study in healthy volunteer, and this study created the basis for the future study in order to find a correct dose and clinical dose. Moving to the EAGLE-2 and EAGLE-3 study, the study compared the efficacy of gepotidacin against the standard of care, nitrofurantoin, that is the standard of care in uncomplicated urinary tract infection. But the EAGLE-2 and EAGLE-3 phase 3 study has been stopped early for the efficacy following the pre-planning interim analysis by the Independent Data Monitoring Committee in November 2022. Moving to another investigational drug for the treatment of uncomplicated urinary tract infection. This is sulopenem. Sulopenem is an oral carbapenem. In this study, SURE-1 trial, sulopenem has been compared with ciprofloxacin. Sulopenem was superior to ciprofloxacin in patients affected by uncomplicated UTI due to ciprofloxacin resistance pathogen, and moreover, sulopenem is inferior in patients with isolated susceptibility to fluoroquinolone. Moving to another history. This is about a complicated urinary tract infection. In this study, we found a very interesting finding about the use of 2B-penem, an oral carbapenem, for the treatment of complicated urinary tract infection and acute pyelonephritis. Tebipenem was non-inferior in the study to intravenous ertapenem in the treatment of complicated UTI and acute pyelonephritis, and showed a similar safety profile. Very interesting results. I would conclude my talk highlight two important aspects when we looking for a new drug, an investigational drug for the management of complicated urinary tract infection. In fact, I think that the new antibiotic discovery is based on two important aspects: the enzymology, of course, and the bacterial genotype. For instance, here you can see sort of a lot of beta-lactamase inhibitor, and as you can see here, the beta-lactamase inhibitor are able to act only against specific class of carbapenemases. And then moving to the genotype, another important aspect to consider in everyday clinical practice in the management of complicated urinary tract infection. You will know that the genotype has an impact in the choice of antibiotic. For instance, as you know, we need to avoid the use of piptazo in MPC bacteria or the use of cefepime in ESBL bacteria. So, in conclusion, this, as you can see here, you are a summarize of all potential American Food and Drug Administration approval of selected investigational antibiotics stratified by years, imipenem plus relebactam or gepotidacin, and in the last year, and very interesting promise antibiotics is murepavadin for the treatment of Pseudomonas aeruginosa. However, I hope to see in the, as soon as possible, new antibiotics and new strategy treatment to use in everyday clinical practice. Thank you.
Yeah, Tommaso, thank you very much for this very encompassing review about the now again filling up pipeline of new antibiotics, as we had a so-called discovery void over the last years, even decades, because novel antibiotics have not been put further in the discovery. So therefore, we are very grateful that we have some couple of new substances. So you mentioned some of them, a new in-class antibiotic, gepotidacin, a new triacylsinaphthalene antibiotic, and the oral penems and carbapenems. And then you also went into detail. So I think I agree with you that the most important problem are gram-negative bacteria and enterobacteria. And you mentioned that this is definitely one of the challenges we face in the future. So from your perspective, because these are oral antibiotics, I think this is also a big problem what we have in clinical practice, that we don't have oral antibiotics available for multi-drug resistant infections. So what of those, strategies using antibiotics is in your practice a common strategy is on the one hand to use old ones or new ones and to preserve the new ones, because that is another issue. If we have the new antibiotics available, hopefully soon, we need to preserve them for the future. So how would you handle that, or how are you handling that in your practice already?
Yeah, thank you, Florian, because this is a really challenge in everyday clinical practice, because we need to consider to perform in everyday antimicrobial stewardship principle. We need to improve our adherence to antimicrobial stewardship principle, starting from the management of uncomplicated urinary tract infection. Because I think that in complicated urinary tract infection, we need to use antibiotics. Of course, because we have a bacterial infection that could be a severe infection and could be related to the diet of the patients. But in recurrent UTI, we have, of course, in infectious disease, bacterial disease, but in recurrent urinary tract infection, we need to improve our antimicrobial stewardship, because the management of recurrent UTI is strictly associated with a high risk of recurrence. And moreover, the patients who experience a recurrent UTI have a very frequent use of antibiotic. Now, in my everyday clinical practice, I take into account my local prevalence resistance. This is very important in order to use active antibiotic, and in order to preserve the use of carbapenem, for example, because now the carbapenem represents the last line for the treatment of urinary tract infection.
And just to prompt you, if you have oral carbapenems, would that be a different, or would that facilitate emergence of resistance of carbapenemases? So is that also, on the one hand, we are of course grateful that we will have maybe these products at our hands, but there's also a challenge not to overuse that, especially because you have shown that the carbapenemases, the metallobeta-lactamases, are very difficult to treat.
Yeah, sure. I totally agree with you. In fact, in our department, we start a strict collaboration with the infectious disease in order to find the best empirical treatment in the first phase, in waiting to have microbiological findings. And I think that also for urologists, we need to know the real bacterial resistance, local prevalence, and the real effectivity of each class of antibiotic, in particular what carbapenem is more specific and more active against the isolated.
So coming back to José's case, I mean, it's a typical case. Patient has repeated uncomplicated cystitis. At that time, it was treated with ciprofloxacin. I don't know if you will do that anymore again. And then in the end, you have a multi-drug resistant organism. So from a simple case, over the weeks, months, and years, you will have a very complex and complicated case to treat.
Yeah.
Would you do something different retrospectively in this case?
Yeah, first of all, this is the case, but the first thing that you have to do to study correctly the case, because it's very common that the patient come to my clinic and say, I had a urinary infection, and you prescribe antibiotic. But if you analyze and ask about the symptoms, not everything, not all urinary symptoms are infection.
Yes.
So first of all, you have to rule out other things that are not infection.
Like what? Like overactive bladder?
Bladder or a vaginal infection.
Yeah.
And also in men, and urethritis can be and the treatment is different. You can choose the same antibiotics, and sometimes you have a candida, especially in women with recurrent infection. So the first thing to evaluate correctly. The second thing, when the patient has a recurrent urinary infection, I speak with my patient and I explain the different alternatives. Because in my opinion, it's not a decision of the medical doctor, the urologist, of the primary care. It's a decision that we have to reach an agreement, both, in order to choose antibiotic, because in some cases we can deal with mild symptomatic infection without antibiotics. For example, with ibuprofen in some selected cases, and the patient had to deal with other prevention measures without antibiotics.
When would you start the preventive measures in such a patient? So as I understood, the first 5 or 6 episodes were entirely treated with an antibiotic, so without applying preventive strategies.
Yes. I just start from the beginning. The first of all is explain to the patient what in an infection and how can prevent the infections, because it's so common in my clinic that the patient with recurrent infection come to my clinic and think, yes, I had a in my genital part, but he was during 30 seconds or 1 minute to avoid infection, and something is bad. So it's good to dedicate the time to explain what he can do for prevent the infections.
And what exactly is that? What could you give it at our hands? The risk factors, for example, Masa, you worked about the risk factors. So what?
Yes, this is a very important aspect, but let me to highlight an important aspect of the Jose case. The question is, the second episode, are you sure that is a failure of the therapy, or is a new infection? Because if is a failure, yes, antibiotic is correctly, and we need to start with antibiotic. But the second episode is a recurrence. We need to start with a preventive management, of course, vaccination, for example.
Right away, so you could start very early with preventive measurement. Yes.
From the beginning,
From the beginning almost.
Yeah. So coming back to the risk factor evaluation, this is very important, because in everyday clinical practice we have no more time to discuss with the patient about the risk factor.
That's the problem, It's a very limited time, even in our specialized centers, So and most of these patients will be seen by GPs. They even have less time.
Yes.
GP or gynecologist, for example.
Gynecologist, yes.
So GP and gynecologist are the first line of the treatment of uncomplicated UTI. Urologist, infectious disease, probably at the second and third line. However, we need to have time to perform a very simple counseling about the behavior modification, increase the water intake, avoid some sexual practice, also regulate the bowel function, increase the vegetable intake, and so and so. But in everyday clinical practice, we have no time. We have more to prescribe antibiotic and go.
It's easier. That's why it is overused also.
Yeah.
Yes, that's
is not able to change the natural history of recurrent UTI. The antibiotic is able to treat the acute episode, of course, but it's not able to prevent recurrence. This is the point.
And what preventive strategies are you both applying, non-antimicrobial strategies, to those patients that was in the case report of Jose? Maybe what is, apart from behavioral
Yes.
counseling, I would say, that's certainly a very important point, and Tommaso has shown that it is effective if you do that. But you still have a number of patients that have breakthrough infections. So what are your typical strategies in these patients?
I think that cranberry and the manose is...
So cranberry, do you use it because the evidence is conflicting? We have various studies in the last years. Some were positive, others were negative. So you still use that?
I use.
You use it, okay.
I think the most important thing is the amount of cranberry that they give to the patient. In my opinion, a juice is not...
cannot do it because it's not concentrated enough.
And usually they don't have a side effect with cranberry. So I start with cranberry.
Capsules probably, or...
Yes, capsules. Yes.
Capsules.
Regarding probiotics, in a patient with an infection each month, I think it can be good, the probiotic, because I'm pretty sure that the microbiome of the gut and in the bladder change. So
yes,
I recommend, especially in patients with many frequent infection. Sometimes I explain the alternative in the hyaluronic acid and chondroitin sulfate. In some patients is indicated, but it's an invasive procedure, and the result is in some cases it's okay. And also the immunoprophylaxis.
Okay.
I use regarding in each country there are different vaccines. For example, the immunoprophylaxis that we had in Spain is good, but we need to inform the patient what to expect, because the cranberry and the manosa, we had better results with E. coli than with other pathogens. As with the immunoprophylaxis, we had better results in patients with premenopausal and sexual related infection. And for sure, for postmenopausal women, I recommend estrogens. I think
estrogen, that's also important because that's a very personalized approach. Estrogens. Would you do something in addition, or is that more or less the armamentarium we have at our hand?
Totally agree with Jose. Depends by the patients, of course, the age of the patients, the risk factor, and so and so. But moreover, I think that depends also from the isolated strain. In case of E. coli, immunoprophylaxis, of course, is the best option. And in other atypical bacteria, such as gram-positive or Pseudomonas klebsiella, and so, probably the immunoprophylaxis is not able to obtain a clinical success. However, I think that our approach depends also by what the patients ask for us. The age, of course, is the most important factor. The patient perspective, of course, is another important aspect, and the previous isolated bacteria. But don't forget to discuss with the patient about to do not treat asymptomatic bacteriuria. Yes. This is another important aspect.
Yes.
And that they in everyday clinical practice do not take always into account.
So now we closely come to an end. What I would like to focus in the last minutes is, you showed that there are new antibiotics around. We even have a new in-class antibiotic like gepotidacin. We have novel carbapenems. We know that we have to use them very carefully. Are there any other strategies you would like to discuss that are in the pipeline, that are still experimental? So where we have studies or need to perform studies. You are, for example, alluding also to vaccination.
Yes, really, the vaccination that we have available currently is not vaccination in reality. It's immunostimulation. But there are some studies, especially in rat, and they started to do some preliminary study in human with vaccination with the whole bacteria with glucopeptide of the E. coli, that the result is promising, and especially in patients with resistant bacteria. is promising. But I think it's the future, and in some years, I think that we can develop protection to the patient for infection and to avoid resistant infection.
Tomas, what about phages? I frequently see patients, they want phages, so I don't use them in routine. Are they something yet for everyday routine, or is it still experimental?
So, very interesting topic, the role of phages in recurrent urinary tract infection. Unfortunately, in Italy, we have no able to use phages, but we have some international experience about the effectivity of phage against E. coli, for example, E. coli recurrent UTI. But I would like to come back to the vaccination, that I think that is the real future of the management of recurrent UTI, because we need to find a antibiotic sparing approach.
Yes.
Probably the vaccine is the future, and probably the vaccine, oral vaccine, because we have two types of vaccination, oral or parental administration vaccine, and probably the oral vaccine is the future that we need to get, we will use in everyday clinical practice.
And maybe a last strategy, also very experimental, probably only for very specific patients, microbiota transplantation, fecal transplantation or urine transplantation is also something that is coming up. More discussion is coming up, so where do we stand there?
Well, I think that this period is not in urinary tract infection, but in patients with Clostridium difficile.
That is where it started.
Yes,
now,
where it started.
Is there a role in urinary tract infections also?
I think so, because for sure the bacteria that are implicated in the urinary tract infection are fecal bacteria in some way, and I think it has a role, and the thing are changes. I remember when I started my residence, the urine was sterile.
Yes.
And nowadays the urine is not sterile.
Yes.
So I think it's in very selective patient, preferably to complicated infection with hospitalization, probably in kidney, hepatic, and transplantation patient, is going to be an alternative to avoid and to cure infection.
So for instance, I regularly prescribe microbiota analysis in patients with the recurrent UTI.
Lactobacilli or...
Yeah. And a chronic bacterial prostatitis, for example.
Yes.
And the patient perform a microbiota analysis in the stool, of course. But I think that we are so far from the real clinical applicability of the results of microbiota in the stool and the plane of strategy. Probably in the future we need to have a multi pathway strategy, vaccine, immunomodulation, and probiotics, for example, that is able to join activity against the recurrence.
So you can add more or different mode of action.
Yes, and in my clinic, it's important. I evaluate the pH of the urine.
Yes.
Because you have to have in mind that not all the antibiotics work
in the acidic environment. Yes, that's very important. You could even adapt the pH to the optimum activity of the antibiotic.
Sure.
Yes.
So I thank you very much for the talks, for the presentations. I think we covered a wide spectrum. We elucidated the problem of antimicrobial resistance. We elucidated the novel developments of novel antibiotics. We know very much that we need to preserve this antibiotic. So each novel antibiotic has to be preserved and very carefully be administered. And I think we also covered quite a number of alternative strategies. There are strategies around that we can already use in clinical practice, and there are strategies that are still experimental, and we need more studies, and we need to include those patients maybe in clinical studies. And therefore, I thank you very much again on this Sunday. And here I close this roundtable discussion on UTI and multi-drug resistant infections in urology. Thank you very much at home.